Yeah. So my clock shows 12:30, but welcome to everyone this afternoon for our July 3rd Journal Club. We're so pleased to have Dr. Sophie Clark here from University of Colorado. And we'll let you go first, Sophie, and whatever time left, I can present my pearls from the AGS conference.
Okay, perfect. Thank you so much. So this was an article that actually Dr. Leslie Eber sent to me. We were working on a gabapentin deprescribing initiative, and I just thought this was a really interesting paper. It surprised me a little bit. It doesn't take place in the long-term care setting, but I think it's a pretty well done study. And so I just wanted to talk about it a little bit. Um, so just to start off with, I just wanted to talk a little bit about the history of gabapentin, because as you know, it's prescribed a lot more frequently, both in the community and in long-term care settings. It's often used as an opiate-sparing agent and is something that we often think of as less risky than compared to opiates, but certainly we all know has side effects associated with its use. And so in terms of what gabapentin is actually FDA approved for and what there's evidence for, the FDA has approved gabapentin for partial seizures and post-herpetic neuralgia. There is some evidence for diabetic neuropathy, but it's not FDA approved for that. But in terms of chronic pain, there really isn't strong evidence that it's helpful, or like sciatica type pain, or just some of the other anxiety, some of the other indications that we commonly see it prescribed for. There really isn't evidence for that use, and also the FDA has not approved it for its use. And some of you might be aware that there was actually a large lawsuit in 2014 where the pharmaceutical company settled a lawsuit because they were found to illegally promote the off-label use of gabapentin. So some of the practice that we see now might still come from that historical practice. And at one point, 95% of Medicaid patients were prescribed gabapentin for off-label use. That sounds confusing. Not 95% of patients, sorry, 95% of the reasons that people were prescribed gabapentin were for off-label use, not 95% of Medicaid patients. So just some interesting background for this study. So this study compared patients who had a diagnosis of like diabetic neuropathies and like neuropathic pain, like had a very specific definition of what the indications for use were. So it wasn't for people who had chronic pain or seizures or anything else. They were looking at the risk of falls in older adults, so people who were 65 or older, and they looked at the risk of falls in the 6 months after starting duloxetine and compared it to gabapentin. The way that they did that is it was a new user study, and there was an active comparator group, meaning that there was gabapentin was being compared to something else. Typically, other trials that have looked at the risks of gabapentin use have compared gabapentin users to non-gabapentin users, and so for that reason, it's hard to kind of draw conclusions just because bias is involved in terms of why you might be prescribed gabapentin or not. And it was done using a target trial emulation, meaning that it was based on retrospective data. And I'm going to talk a little bit more about target trial emulation, but it's basically a really rigorous way of looking at retrospective data and doing the best that you can, acknowledging that there's always going to be some question since it's not a randomized control trial, but really trying to be rigorous in your evaluation of observational data. So it looked at adults with at least one prescription of duloxetine or gabapentin being filled between January 2014 and December 2021. The primary outcome they looked at was an ICD code for an outpatient or an inpatient visit for a fall-related visit or injury. So that's not going to capture all falls. It's only going to capture falls where people actually seek medical attention for it. So it might actually be underreporting the incidence of falls. But in some ways, if a fall doesn't result in the difference should be equal between the gabapentin and the duloxetine groups. And also there's a question of if it's a minor fall without an injury, maybe we care about that less than other falls. And then secondary outcome was looking for a hospitalization or ED visit for fall hip fracture. 6 months after initiation. Inclusion or exclusion criteria. So looking at older adults, 65 years or older, they had to have an ICD-10 code for post-herpetic neuralgia, diabetic neuropathy, or fibromyalgia. It couldn't be for so basically, this is not looking at patients who are prescribed gabapentin for chronic pain. And then they had to be enrolled for 365 days after cohort entry. Exclusion criteria was if they were already on gabapentin or duloxetine, if they had some other active cancer, seizure disorder, or depression or anxiety, or if they filled an AED in the last 365 days, just because gabapentin can be an anti-epileptic medication. And so basically what they used was they used a type of trial called a target trial emulation. So that's when you use observational data and you try your best to replicate the conditions of a randomized control trial. So what you do when you're planning a target trial emulation is you formulate a question, you pretend like you're doing a randomized control trial, and then you try to match up those methods that you would have used in the randomized control trial in the target trial emulation. So it's sort of thought to be a very rigorous way to look at observational data. So down here, for example, thinking about if you were to design this trial and you were looking at doing a randomized control trial, thinking about what your population would look like, and then using that to design your emulation trial. And so what they did is, in terms of statistical analysis, if you look at the paper, they have tables and tables of basically the covariates that they adjusted for. So basically because people are not being randomly assigned to get gabapentin versus duloxetine, trying to think about reasons why clinicians might prescribe one over the other. And so thinking about comorbidities, thinking about psychiatric diagnoses. And so they did that for a wide number of conditions. And then they had pretty intensive sensitivity and subgroup analysis. And then they looked at negative control rates. So trying to think about things that should in no way be related to why you're prescribed gabapentin versus duloxetine, and just making sure that that those two treatment groups agree on those things. And so when they looked at the trial, they found that incident users of duloxetine actually fell of gabapentin actually fell half as much as those who had gabapentin. So they actually found the risk of incident falls to be lower in patients who were prescribed gabapentin compared to duloxetine, which I was a little bit surprised about. But there was no difference based on the secondary outcome. So no difference in terms of hip fracture rates, hospitalizations, or things like that. And so I just sort of wanted to see, so in terms of this study, I think one of the strengths of the study is that it compared gabapentin users to gabapentin users to duloxetine users. So I think that's certainly a strength. I think that gives us more information about what we can extrapolate on in terms of gabapentin. And I also don't want the take-home message to be that there's no side effects of gabapentin and that we should all be using it willy-nilly. That's not what I think that this study is telling us. I think one of the shortcomings of this study is that the medium initial dose of titration was gabapentin 200 milligrams, which is a very small dose compared to what we see of other people. So I don't think that we can extrapolate this to higher doses. I don't think we can extrapolate this to people who are on it for chronic pain or other things like that. This was also not a nursing home population. And also it was also a limited patient population, so didn't include things like VA patients or things like that. And so I just kind of wanted to open the floor and see what you guys thought about this paper, and any thoughts or comments you guys had.
Thank you. Fascinating. And thanks for explaining the methods so clearly. I hadn't heard of that type of trial. Greg, it looks like you came off mute. Do you have a question or comment?
Yeah, no, I think your presentation was excellent. This is obviously one of my pet peeves because that lawsuit that you quoted from 2014 was actually the third time the federal government had sued him for the same thing. And there's wonderful articles from the first time, 2006, where they paid $495 million in settlement, and agreed not to mismarket it for neuropathic pain, but they kept doing it anyway. So they were also sued by the federal government in 2011 and then 2014, three different times. And right now they're right at $1 billion in fines. But for the seventh best selling drug in the world, who cares? Because they make about $6 to $7 billion a year in revenue. So they kind of keep doing it. Um, and actually the only other thing I'll say in that regard is in the original trial, the New England Journal and Annals ran wonderful articles reviewing the trial because they had to release documents and I'd have to go back through and reread them. But in essence, the company did 27 randomized controlled trials. Of the 27 trials, two of them showed that Neurontin was better than placebo for neuropathic pain. Two of them showed placebo was better, and 23 showed no difference whatsoever. But the only two trials that they published were the two that showed that Neurontin was better. And unfortunately, if you go to Cochrane or if you go do reviews, and try to pull the literature, part of the settlement in 2006 was that, yeah, they'd pay $495 million fine or a settlement. They'd agree not to mismarket it. But what the government had to concede was that they wouldn't make them publish the other 25 studies. So if you go pull studies, you won't find those unless you go to the court documents from 2006. You won't find those 25 studies. That's it.
It is an amazing story. Yeah. And when I think about if I was going to choose gabapentin versus duloxetine for some off-label use for pain and neuropathy, I might look at the study and think about the risks, but I think I would probably focus on the benefits. Do you feel like there are any better indications for using duloxetine over gabapentin for the benefits for neuropathic pain and some of those other uses we use it for?
I think I think what this made me think more about was just that duloxetine is maybe not as quite as innocuous as we think. But I still think that duloxetine, like especially because there's such a link right between chronic pain and neuropathic pain, and duloxetine can also help with the nerve component or the mood component too. So I think for that reason, I often choose duloxetine over gabapentin because it can often help with some of those mood symptoms too. And also it doesn't cause sleepiness in the same way that gabapentin does.
Mhm, mhm.
Yeah. Uh, Thank you so much, Sophie, for doing such a wonderful presentation. The other things I think about when I think about this are a couple of things. First of all, of course, we don't know how many people who fell at home and didn't need additional care. But I think those falls are important. I think that sometimes people then, because they're sore or they are hurt, they don't want to go to the doctor. Maybe they don't have access to transportation to the doctor or not access to a doctor. And I'm sorry, I hope that can you guys still hear me?
Yes,
Oh, good.
I can.
So I think that can also may influence the way people move here on. Maybe they didn't have a fall that needed medical care the first fall, but maybe that led to a second fall because they had some pain or some minor injury, and then they were walking differently. So I think that those additional falls that weren't picked up maybe would swing it the other way. I think we just don't know. And then when I look at the data just for gabapentin independently, not kind of compared to anything else, and we look at the efficacy rates of gabapentin for several different kinds of pain, even post-herpetic pain, neuropathy, chronic pain, gabapentin doesn't really pan out for many people. So I think that our likelihood of success when starting gabapentin is, fairly small. And I think that that also influences whether I start gabapentin or not to begin with, because my chances of being successful here are so small, yet my chances of side effects besides the falls are fairly great.
Mhm.
Thanks.
That risk and benefit calculation becomes so important. Yeah. Any other comments or questions for Dr. Clark? Good. Well, thank you. Wonderful presentation, wonderful discussion.
Perfect. Can I just mention one other thing really quickly?
Yes, I was
Oh.
hoping you would.
Yes. So one other thing, just to be aware of, we are looking for volunteers to host our palliative care fellows for about half a day, once per month, one fellow at a time. Our goal is to just help them see what community nursing homes look like, because they're sending a lot of people and talking a lot about subacute rehab, nursing home level of care, but really don't have a good understanding of what those care settings look like, and they don't really know how hospice is delivered in that setting. And so just hoping to have some of our fellows work with you all. Again, it should be one half day per month, and really anyone who is willing to and open to hosting them would be great. If you are interested, just send me a message in the chat or email me here, and my email address, I'll also put it in the chat, but it's sophie.clark@cuanschutz.edu. Okay, thank you.
Thank you. And thank you for educating the palliative care fellows. I'm trying to share my screen. I don't know if it's working, but I will go next. And I have a few tidbits that I learned from the annual American Geriatrics Society conference, which was in person and online this year. I took a little time just to get some CME from that conference, and there were a lot of great things that I learned. So I just picked a few out that I thought might be helpful for Journal Club. I hope that you can see something now. So I just picked a few a few presentations that were very interesting to me. The first one was a review of several journal articles, including this one, the Thickened Liquids Study. Last May, there was a study published regarding thickened liquids, studying nearly 9,000 hospitalized patients in New York who had both dementia and dysphagia. Their average length of stay was 7.3 days, and they compared the outcomes of the patients for thickened liquids versus thin liquids. They have about half of them on each side of that treatment. The people who had thick liquids did incur fewer episodes of intubation, but there were more episodes of pneumonia and coughing and choking. And there was no difference, however, in the hospital mortality, dehydration, no difference in the length of stay or in 30-day readmission. And one of the graphs that was shown to demonstrate it looks like this. You could see that over the course of the hospital stay, the hospital survival rates did not differ between thick diet and liquid diet for all these patients who had dementia plus dysphagia. One of the limitations of this kind of study is that it was retrospective. I enjoyed listening to you, Sophie, talking about that trial emulation, target emulation. I didn't see that word in this study at all. It was retrospective, it was observational. They did have propensity matching. I don't know if that brings it a little bit closer to what you were talking about, but overall, they didn't find a difference in survival. The study wasn't able to divide up people into like severe dysphagia versus mild dysphagia. So maybe people who had the worst dysphagia were recommended thick diets or something, but the study was not able to tease that out. So to me, this is very important because we use these thickened diet recommendations all the time. And in an accompanying editorial, the authors argued that if someone is recommending that your patients get thickened liquids, don't just automatically put that order in place. We need to start by acknowledging some of the limitations of this evidence. There is no great evidence that shows that thickening liquids will protect people from those outcomes that are really important, like dying, like getting aspiration pneumonia. We need to put ourselves in the shoes of our patients. And as part of the presentation at this conference, they invited some audience members up to the stage to come and drink some samples of the thickened liquids. And you could just see everyone's face kind of go, ugh, I wouldn't want to drink this. And not only they didn't enjoy that little cup of thickened liquids, they just couldn't see themselves doing it for every meal of every day and being permanently on that diet. When we get this recommendation, we need to work with our speech language pathologist. And the goal shouldn't be to find, oh, what is the best diet or what is the safest diet? This should be, what is the best diet that will meet this patient's goals and maintain quality of life given the current evidence-based? And I think that sometimes I've seen the conversation be a little bit more black and white than that. I've heard conversations where patients are told, if you don't follow the thickened liquid diet, I think you should be on hospice. Well, we can see from this data that just because you're on a thin diet instead of thickened diet when you have dysphagia doesn't mean you just die the next day. So I think this is very important just to be aware of the evidence or lack of evidence. There was a section about prescribing medications in heart failure and how tricky that can be. We know that SGLT2 inhibitors like dapagliflozin and empagliflozin, they can have benefits to diabetes for lowering blood sugars without as high of a risk of hypoglycemia as some other medications. It does have some risks for mortality and morbidity in heart failure, especially people with reduced ejection fraction, and it can be predictive in kidney disease. But there are risks to the medications as well, and we have to be very aware of them, especially for our frail older patients. So some of the strategies that were given to reduce the risks that can come with SGLT2 inhibitors include the ones listed on this slide. If you're adding the medication for someone with heart failure and they're already on an insulin regimen or sulfonylurea, you might have to decrease the dose of that other medication. It can lower the blood pressure a bit. You could have some parameters when you first start an SGLT2 inhibitor to hold if the systolic blood pressure goes below 90. We can put hold parameters or be cautious of holding it if the creatinine increases over 30%. A small increase is actually expected and should get better over time, but any more than that, you have to be cautious. If someone has a GFR that's less than 25, there are some different criteria that are being used to evaluate the safety of these medications. In some cases, you might want to stop the medication or not start an SGLT2 inhibitor. In some cases, you might want to continue it. Because this medication can cause what they call the euglycemic diabetic ketoacidosis, we should consider holding SGLT2 inhibitors during times of low oral intake, such as when someone has an active infection and they're not taking in much fluids. And finally, one of the studies has shown that during transfers of care, during transitions of care, these orders get messed up at least 10 to 15% of the time. And we need to be very cautious of what's happening when patients are going in and out of SNFs in the hospital and to home. We should add a very clear diagnosis to medications that are being used, whether they're for heart failure or diabetes. And whenever we're treating people for heart failure or chronic kidney disease, add SGLT2 inhibitors to our checklist so we're aware of whether they should be on there or not. A similar conversation happened about GLP-1 agonists, medications like semaglutide, delaglutide. They can have some benefits. You can have weight loss of fat, if that's what's desired. It can help improve quality of life and mortality in heart failure and in obesity. There are many risks as well. It can lead to some enough weight loss to cause malnutrition or sarcopenia. And in some studies with certain GLP-1 agonists, there can be actually an increase in mortality. I know that in practice, the main adverse effect I've heard about for GLP-1 agonists are the GI side effects, the nausea and the GI upset. Here are some tricks to titrate a GLP-1 agonist to address those side effects. If a person has adverse effects, slow down the escalation. Instead of increasing the dose every 1 or 2 weeks, just increase the dose every 2 to 4 weeks evaluate before moving on to the next dose. You can suspend the treatment temporarily if someone is not tolerating it. And then if side effects appear after escalating the dose, you can decrease and go to the prior dose and then slowly increase again until you reach the target. And certainly if the people have side effects that extend beyond a few weeks, we should be looking for other causes of GI upset and trying to help the person do some lifestyle modifications or workup to try to address other GI issues that could be causing their symptoms. And we'll just do one more topic here. Osteoporosis came up. And this was very interesting to me. To screen for osteoporosis using a DEXA scan, the number needed to screen to prevent death in women over the age of 85 is much lower than many of the other screening tools that we have to assess for things like cancer. I think that for our long-term care population, there might be people for who this is very important, and we don't want to forget how important it can be to screen for osteoporosis. By doing so, we might be able to prevent a death, prevent a fracture, and prevent the suffering that comes from fractures. There are 3 ways to diagnose osteoporosis. One is if someone has a fragility fracture. Someone falls from a ground level height and they end up breaking a hip. If someone has vertebral fractures on the x-ray, they meet the definition for osteoporosis, and you might consider treatment. Someone who's had a DEXA scan with a T-score in any site, whether it's their spine or their hips, that T-score is less than -2.5, they have osteoporosis. And with or without DEXA scan results, with or without a fragility fracture, we can calculate a FRAX score for our patients. There are several FRAX scores out there based on the population, based on where your patients live and their race, based on whether you have a DEXA scan or not. And if you're able to have a FRAX score that calculates the 10-year risk of at least 3% for hip fractures or 20% for a major osteoporotic fracture, then your patient has osteoporosis, and you can proceed to talk about treatments. So I will stop there because I had so much fun with the AGS conference and wanted to share some of it with you. And maybe I can fill in any blank spots for future journal clubs if they're available. Okay. Any questions or comments? It looks like there's some good. There's Leah, thank you for your question. How can we get this relevant information to speech therapy and the therapy managers to help change the perception that if we do not use thickened liquids, there is an increase in liability? Yes, that is huge, especially as facilities no longer allow patients and families to sign the diet waivers anymore. Yeah, thank you, Leah. That is just an everyday issue. And I've struggled as well. I think that talking to our facilities does help. I think that talking to them in terms of reducing risk instead of, getting rid of risk can help too if we change kind of the language that we're using. And having our patients talk in terms of risks and benefits rather than absolutes. There's no data saying that if I put you on a thickened diet, you will not get aspiration pneumonia. That simply is not true. There's certainly no evidence that just because you don't follow the diet, you will die and you need to go on hospice. And I think if we can continue those conversations with our therapists, that they can also get this knowledge and help to understand the reason that they turn to you, Leah, and to our providers to override their recommendations. Usually the therapists say, I'm just making a recommendation, you write the order, is because we do have that final say and we get the ability to think about the nuances and the goals of care for the patient and not just a black and white, risky versus not risky. And Dr. McCurry, was the level of dementia taken into consideration for risk and benefit of thickening the liquids? And that was one limitation they acknowledged in that paper. Anyone who had dementia, period, could be included in this study. They did point out that people who are admitted to the hospital with dementia, among those patients, 1 out of 3 do have dysphagia diagnosis. And so I think they just took all comers for this particular study. And Dr. Tan, thanks for joining us. Glad to see you on Journal Club. What is the risk versus benefit of osteoporosis treatment with bisphosphonates for elderly residents who may have trouble swallowing? Yeah, great question. As part of the osteoporosis presentation, the very last part of it was, when do you deprescribe osteoporosis treatment? And if the risks and benefits are not weighing out, we should be stopping those medications. Some of the reasons to stop a bisphosphonate include if someone has a less than 2-year life expectancy, if someone is not walking anymore and they have virtually no risk of falling or a significantly reduced risk of falling, and if they cannot tolerate taking the medication. If someone's having difficulty swallowing their bisphosphonates, they probably shouldn't be taking it. A thickened liquid study, yes, Leslie, I can share that. I thought it was really fascinating and very helpful for me to see dysphagia being studied rigorously. Yeah, I'll share it with the CMDA email list. Thank you. Thank you all for joining us for Journal Club. We will have a Journal Club again the first week of August, along with the CMDA meeting. And Dr. David Shepard will be leading our CMDA meeting, and Dr. Greg Gom will lead Journal Club in August. Thank you.